is a fan of a Marvel? Well, I'm a fan of a DC comic. Because next topic is going to be an Iron Man topic of hematology. Why Iron Man topic? Because of two reasons. Firstly, it is the most common and most prevalent disease worldwide. Secondly, it is the most frequently asked questions in the exam. So let's talk about our topic for today, that is anemia, iron deficiency anemia, and anemia of chronic disease. We'll be also discussing about anemia of chronic disease in this topic because it becomes a very close differential diagnosis when we talk about iron deficiency anemia. So what all we'll be discussing in this topic is hierarchy of hematopoietic stem cell differentiation, importance of iron, transferrin and transferrin receptors, and recommended dietary allowance. Let me begin with telling you the amount of iron required per day. The absorbed iron required per day is 1 milligram per dl in men and 1.4 milligram per dl in women. We'll be also discussing about the causes of iron deficiency anemia that can be categorized into a broader term that is called as demand, supply, and loss. As I told you, it's the most prevalent disease worldwide, accounting for up to 1 million deaths annually. So let's talk about hierarchy of hematopoietic stem cell differentiation. So to understand any topic, we have to go to the base of the topic. If we dissect the topic into, we need to know each and everything, what the topic means. We have to know each synonym, we have to know each full form, we have to know where the cell is, where it belongs, where it is going, where it is differentiating, what it is causing. If we understand at this level, it becomes very easy to understand the lab diagnosis, clinically, and treatment purpose also. So let's begin with the most basic form of iron deficiency anemia, that is at the cellular level. What happens to the erythrocyte, how it differentiates, how a stem cell is formed at a bone marrow level. So at the bone marrow, there is something called as a stem cell, which has a capacity of hematopoietic differentiation. Now, this stem cell has a good potential of multipotent progenitor cell. Why? Because this single cell can differentiate into multiple cells, multiple forms of cells. It can produce RBC, it can produce lymphocytes, it can produce macrophages, it can produce mast cells. How? Now this hematopoietic stem cell is differentiated into three main forms. That is lymphogenetic progenitor, or a lymphomyelogenetic progenitor, or a myeloid progenitor. Now this lymphoid progenitor will divide into either a B cell or a T cell with NK cell progenitor. This lymphoid myeloid gives rise to something called as granulocyte monocyte progenitor. And this myeloid progenitor is going to get divided into erythroid progenitor and a megakaryocyte progenitor. So this is just one stage before the full maturity phase. Now what comes is a mature phase. This is a mature cell. Now what is a mature cell formed out of all these levels? B cell will form B cell, T cell progenitor will form T cell progenitor, and natural killer will form natural killer cells. The middle one, which is a lymphoid myeloid progenitor, will give rise to a number of cells, that is be it basophils, eosinophils, mast cell, monocyte, that we read in our CBC report. So the next one is erythroid precursors. As the name suggests, it gives rise to RBCs. And next comes the megakaryocyte precursors, which give rise to platelets. So this is how a plain hematopoietic potential stem cell is differentiated into a number of different cells. So we understood how a cell is formed from a stem cell, basically from a bone marrow. Now what we have to understand is how important is iron, what a role iron plays, how it is absorbed, how it is metabolized, how it is transferred, how it is stored, how it comes into a play. So what is iron? Iron is an important metal in our body. It plays many vital roles, the most important role being carrying an oxygen. So what is an RBC made of? It's a very simple question that everyone should know. It contains of 2 alpha genes, 2 beta globulin chains, and it contains a heme complex. Now what is a heme complex? Heme complex is basically a protoporphyrin ring along with iron. This iron is in ferrous state. Iron, as I told you, As it is important to the body, it is also toxic because it is a free radical. Iron freely circulating in the cell is toxic at the same time. So, what is the source of iron? Why iron deficiency is common in vegans? Why it is common more in vegetarians? Because the richest source of iron are all the animal products. Especially, iron is in maximum potential capacity is present in red meat. So, what are the vegetarian sources? Green leafy vegetables, nuts, and that's all. Egg has some amount of iron that can be utilized. Other than that, all meat products are the ones which will give you the amount of iron that is required for your daily function. So, as I told you, vegans are the ones who are going to suffer with iron deficiency anemia predominantly. So, what are the source of iron? We'll be discussing how this iron is absorbed, how it goes into the body, how it is stored, how it is utilized to form an RBC, and that's all. So first I'll talk about how it is taken into the body from a dietary source. So when individual consumes any food item that is taken, goes into his esophagus, stomach, and the upper duodenum. Upper duodenum and upper small intestine is the place where iron is absorbed. So in vegetarians, one more issue is this: many of the vegetables have phytates. Those who consume tea immediately after food have tannates and phosphates. These interfere with the absorption of iron. It is found that consuming phytates and phosphates will decrease your iron absorption as much as up to 50%. So when iron is consumed, it is absorbed in the upper duodenum or intestine. How it is absorbed? There is an intestinal villi. This is the intestinal villi. There are the cells, receptors, which will absorb this iron. Now this is bound to a protein called as ferroporotin. This ferroportin is basically a protein, a transporter protein for iron in the intestinal cells. Now this ferroportin is under control of many factors which can upregulate or downregulate. Now, where are the situations? There are certain situations where the function of ferroportin can be upregulated or downregulated. In such situations where the erythropoiesis is very high, where the bone marrow is in need of iron, in those situations, ferroportin function is multiplied. That means it is going to absorb more of the iron from the duodenum and the upper intestine. Now, there are certain situations, certain diseases where the function of ferroportin is downregulated. In those conditions, the amount of iron absorbed in the duodenum and the upper intestine is going to be decreased. Now, how does this occur? Because this ferroportin is under control of many factors. One of such factor is hepcidin. This hepcidin is synthesized in the liver. Now, hepcidin has a direct control on the ferroportin. It causes downregulation of ferroportin. So, more hepcidin synthesis, the more downregulation of ferroportin, the lesser absorption of iron. So, in a normal process, after the iron is bound to the ferroportin, what is going to happen? Once the iron is bound to the ferroportin, it is going to be present in the circulation, in the vessels. Now, the iron in the circulation is bound with transferrin. This cell cycle, the cycle of iron, how is it absorbed, how is it stored? It's very important for you to understand how an iron deficiency anemia presents, how it responds to a treatment. So along with transferrin, it is circulating. Now it is being delivered to the bone marrow. These marrow cells have got erythroid cells. These erythroid cells have got transferrin receptors. Now, these erythroid cells possess a transferrin receptor in the maximum capacity when compared to the rest of the cells. So, these have got transferrin receptors. Transferrin is carrying iron. So, this transferrin is going to bound to this transferrin receptors of erythroid, and it is going to be taken inside the cell. Now, this transferrin iron complex is going to be taken inside the bone marrow erythroid cell. Then, the transferrin is detached and thrown back into the circulation for its action. Okay, now this iron is going to be taken into this erythroid cell. This iron is present in the erythroid cell. Now the amount of iron in the erythroid cell, where it is going to go in the production of heme. So the amount of iron taken up by an erythroid cell, it is not limited. So it is going to take the amount of iron, whatever amount of it is expressed in the transferrin receptor. So some amount of it is going to go to the production of heme. The rest of the iron is going to be free. Now this is going to bond with a protein called as apoferritin. This apoferritin is a storage form of iron. Now this iron with apoferritin will form something called as ferritin. The more you go into clinical practice, the more you're going to hear this word ferritin. Ferritin is basically a stored form of iron. This ferritin, why is it so much useful? Because we can measure this ferritin in our lab. So this will directly tell you what is the amount of stored iron. Also, ferritin is also an indicator of infection or inflammation that is going into a body. So it is a marker of acute phase. So the amount of iron is going, some amount of iron is going into production of heme, some amount is going to get bound with apoferritin and form ferritin. So this is how the iron is absorbed, taken into a bone marrow. Some of them is deviated, some of them is stored. Now this ferritin, where is it stored? Some amount is stored in the muscles, some amount is stored as a form of myoglobin. So when you see in an adult man who is of 60 kilos, around 2500 milligram of iron is present alone in an RBC. And around 1000 is stored in the bone marrow as a iron storage. And around 2 to 3% is only present in the myoglobin, that is in the muscle. So this is the cycle of how an iron is absorbed, how an iron is stored. So whenever an individual goes into an iron deficiency anemia like state, whenever there is an acute blood loss, whenever there is a chronic blood loss, whenever there is an increased requirement of iron, the stored iron primarily from the bone marrow or primarily from the liver is released first. So the response, clinically, he is going to present you only after 3 to 6 months of what his primary cause or for what his primary etiology has been started. So the presentation of iron deficiency anemia, be it of any other etiology, except for the acute blood loss, the presentation is going to be delayed for 3 to 6 months. Why? Because there is a huge amount of stored iron. As I told you, around 1000 milligram of iron is already stored. So whatever anemia causes there, he is going to present to you only after 3 to 6 months. So what are the other source other from a dietary source of iron? Iron can be either you can give him a PRBC transfusion, either you can give him an iron supplement, that is a parenteral supply or an oral supplement of an iron. This is one way where an individual can get iron, other from a dietary source, and other way is from the reticuloendothelial system. So an RBC life cycle is of 120 days. So on an average, every day, 1% of all our RBCs are replaced, are produced new. So what is going to happen to these aged RBCs? What is going to happen to these senile RBCs? These senile RBCs are going into a reticuloendothelial system, primarily the spleen. There, they are going to undergo hemolysis. This hemolysis is planned. It occurs in everyone. It occurs in me. It occurs in you. So this is a process where old RBCs are replaced by new RBCs. Now old RBCs are basically it has again a hemoglobin, it has a protoporphyrin ring, it has alpha chain, beta chain. So when this hemoglobin is, when this RBC is lysed, globin chains are going into your amino acid pool, protoporphyrin is going to lyse, and there is a release of iron. So this iron from the reticuloendothelial system again becomes a precursor for a synthesis of a new RBC. Now, in situations, now you can say, sir, why does a patient have an anemia in case of hemolytic anemia? While hemolysis causes a free iron release, the human body can utilize the same iron for the production of new RBCs. That is not the case, because in hemolytic anemia, hemolysis can occur intravascular and extravascular also. So the hemolysis that is going to occur in reticuloendothelial system is only going to help you to procure that iron that is going to be seen from an RBC. So if there is any intravascular hemolysis, the iron is going to be freely circulated in the circulation and it is readily inactivated. So that is not at all useful. And in conditions where there is a much requirement of iron, there might be a requirement of not less than 6 to 8 fold of erythropoiesis that cannot be met by hemolysis, that cannot be met by reticuloendothelial system, that can never be met by the iron that you are getting from reticuloendothelial system. Now, when we talk about iron, I told you the sources of iron are very scarce, especially in vegetarians. And also the other problem is bioavailability. The iron that you're going to take, it has a very poor bioavailability. So when I told you in the first slide, an individual, a male will require 1 milligram per day of iron. That is an absorbed dose. To reach that 1 milligram per day, he has to consume at least 15 times of what the dose I have told you. Why? Because bioavailability is somewhere between 6 to 12% only. So if you consume 100 milligram of iron, only 6% is going to be absorbed in your blood. And that too, a lot of interactions are there. As I previously also told you, phosphates, phytates, tannates, they are all going to interfere with your iron absorption. So moving ahead, what happens when an individual goes into a iron deficiency state? As I told you, whatever might be the etiology of iron deficiency. As I told you, the causes of, when they ask you, what are the causes of iron deficiency anemia? It is very easy to memorize it because it can be divided into an increased demand, an decreased supply, and increased loss. So when is the loss of iron in the body? Very easy. When you ask yourself where is the iron is being lost, is by blood loss. So you categorize into acute blood loss or a chronic blood loss. What is an acute blood loss? Someone had a trauma, he's lost a lot of blood. That is an acute blood loss. What is a chronic blood loss? Someone who has an upper GI ulcer, who has a colorectal ulcer, who has a colorectitis, who has any upper GI system infection, who has a prolonged epistaxis, or a woman who is having a menorrhagia, they all fit into chronic blood loss. So this variety is a blood loss, chronic or acute, which is leading to your iron deficiency anemia. So the more amount of blood loss, the more amount of iron is being lost. That same amount of iron is not being replaced in your diet. Okay. So what are the other cause? The increase in demand. So what are the situations where a body will demand more of iron? First, a newborn. A newborn will have a significant changes as soon as he comes into life. So he has to produce an adult hemoglobin when he reaches up to 6 months. So there is an increased demand of iron in a newborn. Second, when there is an adolescent growth spurt, till a child is of 6 or 7 year old, he is short and his body stature is low, and suddenly there is a growth spurt because of hormones, and suddenly the amount of iron required, the amount of RBCs, they are all going to multiply, and there is a huge requirement of iron that is not regularly met by the amount of iron that he is going to consume. Second is adolescence. First is newborn, second is adolescence, third, a female who's having menorrhagia, who is bleeding more than the normal, some individuals may bleed up to 8 to 10 days and present with severe iron deficiency anemia. Fourth, in pregnancy. In pregnancy, the woman has to give all the precursors that are required to form a fetal hemoglobin. So amount of iron taken by her has to be multiplied again. So these are the situations where an individual will require higher requirement. So first we discussed higher loss, that is acute blood loss or a chronic blood loss. In our second category, we discussed individuals who will require a higher demand like newborn, adolescent growth spurt, pregnant woman, or females who have menorrhagia. Third, there is decreased supply. What is supply? What do you mean by supply? Supply basically means decreased intake. When is there a decrease intake? Either I am consuming low iron because of this is the most common cause. Nutritional iron decrease intake is the most common cause of iron deficiency anemia worldwide, especially in third world countries, because few people are so socio-economically backward that they don't get to eat proper amount of nutrition, proper amount of iron containing rich foods. So nutrition anemia is the most common type of anemia which is present especially in India and Southeast Asian countries. So one is decreased intake, you're taking less iron. So where will the body have the iron to produce the amount of RBCs that you require? So that is the first cause. Second, you're taking proper amount of iron, but it is not getting absorbed. Why is it not getting absorbed? First, maybe it is a disease of upper intestine or duodenum. See, when you take iron as a metal which is going through, you follow it and you find where the mistake is. Either you're not taking orally, either you're taking orally properly, but there is no absorption. Why there is no absorption? You may imagine any disease of upper intestine or duodenum which is causing a decreased absorption of iron. Be it celiac disease, be it tropical sprue, be it an individual who has undergone a surgery for morbid obesity. In all these individuals, there is some manipulation with either an upper duodenum or the small intestine where the absorption, where the side where the iron has to get absorbed is disturbed. So iron is not getting absorbed, whatever amount do you eat. So these are the causes of iron deficiency anemia. It becomes very easy when you think in terms of demand, supply, and loss. So it is very easy to memorize. Whenever asked, you answer in such a way only, where there is a decreased supply, increased loss, and increased demand. Now that we have discussed the causes of iron deficiency anemia, we'll go ahead to see what is happening in the backdrop. What is the pathogenesis that is going behind when an individual is suffering from iron deficiency? So, stages of iron deficiency anemia has been classified into a negative iron balance, iron deficient erythropoiesis, and iron deficiency anemia. So as I told you, there is a plenty and abundant amount of iron stores to meet up to 3 to 4 months for an individual without any iron. So in the first stage, when there is no iron being provided because of be it any etiology, what is going to happen? His iron stores from a bone marrow is going to reduce. His erythropoiesis is going to be unaffected. So the iron is going to be mobilized and is being used to produce RBCs. These RBCs are absolutely normal, while his iron stores is getting reduced. Iron stores, we mark it as either 3 to 4 plus. So lower the number, lower the iron store. So the iron store is continuously getting reduced without any effect on the production of the RBCs or the quality of the RBCs. Now what is going to happen if the etiology continues? If it is not corrected at this stage, the next stage is going to be iron deficient erythropoiesis. Now this bone marrow iron is further reduced. It is so much reduced that even the production of RBCs are being affected. Now these iron stores are somewhere between 1 to 2 plus. And the RBCs are also started to form something called as microcytic hypochromic picture. In this situation, what is going to happen? The body is going to try its maximum to utilize the iron, to utilize the reticuloendothelial system iron, and it is going to upregulate whatever it can. It is going to upregulate your ferroportin, it is going to increase your transferrin saturation, it is going to increase the production of RBCs, that is hyperproliferative phase of erythrocytosis. So, if it is not corrected at this stage, what is going to happen is something called as iron deficiency anemia. So what happens in iron deficiency anemia? Totally, iron is not at all there in body, does not exist, neither in the stored form, neither in the RBCs. So the RBCs are further reduced in size and further hypochromic. So this is going to cause a clinical symptom. Now that there is no stored iron, no iron in the RBCs, leads to a microcytic hypochromic anemia. This will have a clinical syndrome. So when evaluated, here there is no any pathological feature in negative iron balance. In iron deficient erythropoiesis, only the iron stores are decreased, while there is only a mild hypochromia. And in iron deficiency anemia, there is full-blown absent iron and full-blown picture on erythropoiesis. So what clinical manifestations can this iron deficiency anemia present? You know, there are innumerable number of causes that clinical features that an iron deficiency anemia can present. So when you memorize a picture like this, it becomes very easy to remember what all it can cause. In individuals, what can it cause in the brain? It can cause cognitive dysfunction. It has been found that an individual whose brain is developing, especially up to 5 years or 6 years of age, when iron is not being produced, it is going to affect with its developmental skills, be it social developmental, be it higher functions, it is going to cause your cognitive dysfunction. On the lips, there's a feature called as chiliosis. On the nails, there's something called as koilonychia. You must be familiar with this term, koilonychia, while reading your practical manuals. There is a spoon-shaped depression, especially in the nails, that is most common feature, most clinically important feature that you see in a patient with iron deficiency anemia. What else it can cause? In the heart, when an individual having an chronic anemia, imagine an individual who previously used to have an hemoglobin of 14 suddenly reduced, or over the period of time reduced to 2 or 3 milligram per dl, the heart has to go and work more. There's some condition which leads to high output cardiac failure. So what are the symptoms it can cause? Apart from the named subjects, it can cause something called as constitutional symptoms. What are the constitutional symptoms? Usually these symptoms are the most common presentation of an individual with iron deficiency anemia. That is either a difficulty in breathing while doing any activity, easy fatigability, an individual becomes very much tired. Earlier that individual used to walk for about 2 or 3 kilometers. Now he or she is hardly able to walk a half a kilometer, which is usually a complaint in these individuals. There can be a loss of appetite. There can be a loss of weight also. So when asked about a clinical feature, remember that along with symptoms, you have to also tell the signs. What are the signs? There can be pallor, which can be seen in the underlids of the eyes. There can be seen in the palm, nails, or in the tongue. And there is chiliosis, there is koilonychia, and constitutional symptoms. Moving ahead, what would you find in a laboratory investigations? There is hemoglobin. That's the most obvious finding that you find. Decrease in serum iron. The normal serum iron would be 80 to 100 microgram per DL. So it can be as less as 50 in Indian population. It can be as high as 150 in a normal individual. So we take a range of 50 to 150 microgram per DL. So anything less than 50 is iron deficiency. Anything less than 20 is severe iron deficiency. So next is transferrin saturation. What is transferrin saturation? As I told you, it's very important to understand how an iron cycle flows, so to understand the lab parameters. Transferrin is an important carrier protein of iron, which is circulating in the blood, which is taking iron from the intestine, delivering it to bone marrow. So measuring transferrin saturation is basically indirect. How? There is a formula. Transferrin saturation is equal to 100 into serum iron divided by TIBC. TIBC is a parameter which you can measure in the lab, and serum iron is a parameter which also you can measure in the lab. Through that, you can derive something called as transferrin saturation. Transferrin saturation is normally 25 to 50%. So more the severe of anemia, transferrin saturation is going to fall more. So when I talked about the stages of iron deficiency anemia, negative iron balance, transferrin saturation will be almost normal or might be somewhere between 30 to 40%. In the second stage, where there is iron deficient erythropoiesis, transferrin saturation will be less than 20%. And the last stage, where there is iron deficiency anemia, transferrin saturation is going to be less than 10%. So transferrin saturation becomes one of the most important parameters for an evaluation of iron deficiency anemia. Next is ferritin. Ferritin, as I told you, it directly reflects something called as stored iron. Ferritin, how is ferritin formed? Iron combines with apoferritin and forms ferritin. Ferritin directly tells you how much of stored iron is there. So ferritin normal value is somewhere in males it is at 100 microgram per liter, and in females it's somewhere at 30 microgram per liter. So a ferritin less than 15 microgram per liter suggests that there is no iron in the body at all. So one important thing about ferritin also you have to note, as I previously told, ferritin is a marker of acute phase. So in situations where there is an underlying inflammation or infection, the ferritin can go up. So when you're doing a ferritin test, you have to make sure that patient is not having any fever, any underlying other etiologies or any other situations where a ferritin can go up, and you might falsely misdiagnose underlying anemia as not anemia. So what is the next investigation? RBC protoporphyrin. So as I told you, what does an RBC structure consist of? 2 alpha chains, 2 beta chains, and a heme complex. The heme complex is a protoporphyrin ring. In that incorporated is your iron. So this iron has to be equal to protoporphyrin ring. So lesser the iron, the more is going to be the rings that are empty. They don't have iron available for them to bind. So the more the severe the iron deficiency anemia, the higher the level of RBC protoporphyrin. So next step is bone marrow iron stores. Nowadays, after the serum ferritin has come, nobody is doing a bone marrow aspiration or biopsy in an individual whom you are suspecting iron deficiency anemia. But still, you can prefer, or still it is indicated where, in such cases where the diagnosis is in query, where you find that there might be some other etiology other than iron deficiency anemia, which I have to find, where in cases where you suspect a myelodysplasia. Okay. When you suspect an individual with iron deficiency anemia and go for a bone marrow, what you see is ineffective erythropoiesis and low total iron stores in a bone marrow in an individual with iron deficiency anemia. So as I told you, you would obviously advise a bone marrow in an individual in whom you're suspecting myelodysplasia. So what would you find in myelodysplasia? Is a ringed sideroblast. So when asked about this topic, you also have to mention that in a close differential diagnosis, myelodysplasia also exists, and you have to also consider bone marrow aspiration in those key situations. So the next investigation is serum level of transferrin receptor protein. As I told you, marrow erythroid cells are the cells which express this transferrin receptor protein to the maximum effect. So lately, even this investigation has gaining importance, but it is not available widely. You just have to know that it is going to come in the future. So this is how a peripheral blood film of an iron deficiency anemia would look like. What would it have? So basically, the shape of a RBC is a biconcave RBC. So the shape is lost when there is a deficiency of iron. So what you can see is something called as anisopoikilocytosis. That is difference in the size and difference in the shape. So what normally the biconcave shape of the RBC should be there, it is lost. Then again there is microcytic hypochromia. You can see here there is the size of the RBC is also reduced, and also the chromia, that is the pigmentation of the RBC, that is also reduced. Along with this, you can see a few teardrop cells, you can see pencil cells. This is also known as pencil or cigar cells. These are quite frequent in patients with iron deficiency anemia. The PBF can come as a spotter in your practical exams also. Hence, it is very important. So let's move on to the treatment strategy of iron deficiency anemia. First and most important cause is eradicate the cause. So what is the cause? Just diagnosing an iron deficiency anemia is not enough. You have to find out the root cause why an individual having an iron deficiency anemia. See, directly arriving that, okay, individual has an iron deficiency anemia, most likely is nutritional, is not done. You have to find out the root cause. You have to find out whether there is an increased demand, whether there is an increased loss, especially and most commonly in elderly, there is an upper gastrointestinal bleed that is usually missed because it is not visible through your naked eyes. In those individuals, you have to go for a stool for occult blood to find out that, okay, there is a significant amount of blood that is being lost in the stool. In those individuals, you have to find the cause and eradicate the cause, because if you give iron supplements or if you give transfusions, that is going to help them temporarily. It is not going to solve their problem at all. So eradicate the cause. Next, transfusions. Where would transfusion help? Don't transfuse all the patients that you find with iron deficiency anemia. No. Iron transfusion is indicated only in certain acute cases where you find an individual with absolutely normal hemoglobin, had a trauma, lost a large amount of blood, now is in failure with a heart rate of more than 150, 160, severely anemic with a hemoglobin of 1 to 2 degrees, 1 to 2%, and then he's having a heart failure. In those situations, transfusion can be helpful, and transfusion must be done in these cases. Don't consider transfusion in a stable patient with anemia. Next is oral iron therapy. So the mnemonic is SFG, and for parenteral iron therapy is SFG and CD. So you can consider ferrous fumarate, ferrous gluconate, or ferrous sulfate. So these are the 3 iron oral preparations that are available. Now, what are the problems with oral iron? Oral iron, first of all, I told you, the bioavailability of ingested iron is very poor. So all these drugs are available in 325 milligrams. But bioavailability, the absorbed dose is somewhere between 60 to 100. So you have to give them in a tedious dose. Do not mix with food. So the next treatment strategy available is parenteral iron therapy. You would consider a parenteral iron therapy in those individuals who are unable to take oral iron, or in whom you feel that an individual is not going to take orally prescribed medicines for a longer time. So what are the options available? Iron dextran, iron sucrose, ferrous fumarate, ferrous gluconate, and ferrous carboxymaltose. This iron dextran now in use is low molecular weight. Earlier was a heavy molecular weight which used to cause a lot of anaphylactic reactions. So the dosages available here with the most commonly used is ferrous carboxymaltose, that is your 750 milligram, and iron dextran would give you around 1500 milligram. Now, in clinical practice, most commonly used drug is ferrous carboxymaltose, although it is little bit expensive. Even iron sucrose can be used, which gives up to 200 milligram of elemental iron. So one thing to watch when you give an parenteral iron is that it has to be mixed with 5% dextrose. Second, watch for anaphylactic reactions. They are very well known to cause life-threatening anaphylactic reactions. So before you give it, give a test dose. So how do you calculate the amount of iron required for a correction? So this is the formula. Formula is body weight in kgs into 2.3 into 15 minus patient's hemoglobin plus 500 or 1000 milligram for the stores, depending upon your etiology. So imagine an individual who is 50 kilos is multiplied into 2.3 into 15 minus, let's imagine his hemoglobin to be around 5 plus 1000. So this would be somewhere between 50 into 2.3, it would be 115 plus into, 10 plus 1000. It would come somewhere between 2115. So this is the total amount of iron required to correct anemia in an individual of 50 kilos with a hemoglobin of 5. So the question for you is, while discussing lab parameters, I told you there's one lab parameter where there is an increase of RBC protoporphyrin because it does not have sufficient iron to be combined with it. So those levels of RBC protoporphyrin is going to go up. Now the question for you is, what are the other causes of increased RBC protoporphyrin? So don't Google for your answers, Google them in your books. So in that way, I feel you will end up reading 2 or more topics of interest. So why are we discussing anemia of chronic disease along with iron deficiency anemia? Because when I told you iron deficiency anemia has a microcytic hypochromic anemia. So the close differential diagnoses are 3. One is thalassemia, second is anemia of chronic disease, third is myelodysplasia. While talking about bone marrow, while talking about a PBF, I told you would go for a bone marrow if you are suspecting myelodysplasia. So how would you differentiate a myelodysplasia from iron deficiency anemia? Go for a bone marrow, you would find a ringed sideroblast, thus you diagnose a myelodysplasia. Now how would you diagnose a thalassemia? Thalassemia is basically a defect in the qualitative production of alpha or beta chains in a hemoglobin, as a result of which there is microcytic hypochromic anemia. But when you go for a lab parameters in thalassemia, serum iron is normal, transferrin saturation is normal, iron stores are normal. So absolutely you wouldn't find any other parameters which are wrong. Even for that, you don't have to go there. You just have to measure something called as Mentzer index, which is elevated in iron deficiency anemia. It basically measures red cell distribution width, which is between 12 to 15, and it is elevated in iron deficiency anemia because iron is not available and there is increase in the shape or increase in the there's a much disturbances in the size or the shape of the RBC. But in thalassemia, it is not going to occur. So how would you differentiate just on a CBC report whether it is a suggestive of thalassemia or iron deficiency anemia? It's just to look at a RDW, red cell distribution width. If it is less than 13, you would diagnose thalassemia or suspect thalassemia. When it is more than 13, you would suspect iron deficiency anemia. So remains the third one, which is anemia of chronic disease. Now what happens in anemia of chronic disease? We'll be discussing in the following slides. So any etiology, which can be an infection, which can be cancer or tissue injury, are going to produce pro-inflammatory cytokines, namely interferon, tumor necrosis factor, interleukins, and hepcidin. So these are main culprits. So memorize these 4 things which are going to cause your anemia of chronic disease. So this is a situation where there is a normal iron store with an impaired iron delivery to the marrow erythroid cell, which will produce a normocytic normochromic anemia and a hypoproliferative marrow. So when you do a peripheral blood film, there is a normocytic normochromic anemia. So in certain situations where an individual is already iron deficient, in those individuals you might also find microcytic hypochromic anemia. So the treatment I'll discuss in the next slide. So let's discuss what is the pathogenesis behind this anemia of chronic disease. As I told you, there is infections, be it any infection, viral or long-term infection that is causing this. Next is cancer, which will lead to your formation of interleukins, interferons, tumor necrosis factor, and hepcidin. So these are the etiological agents. These are by the mechanism which they are going to suppress your production of RBCs. So how are this? These are going to suppress the production of RBCs and cause an anemia in 4 steps. Namely, how will it affect? One, it will directly act on the bone marrow. That is, it will decrease the erythroid stimulation. That is, when I told you the stem cell matures into an erythrocyte, directly suppressing the stem cell is the one etiology. Second etiology would be decrease in the production of EPO, that is your erythropoietin, or decrease in the function of erythropoietin. This is the second method. Third, as you know, hepcidin already this downregulates the function of ferroportin. So the absorbed iron is very less. And the last mechanism is when the iron is stored, it is not released. Prevention of release of stored iron. So by these 4 mechanisms, it is going to cause a clinical situation or a pathological situation where there are enough iron stores in the body, but they are not available for the erythroid marrow. So when you do a lab parameter, what you would find is an almost a similar or normal iron levels that I'll be discussing in the next slide. Here you can see this table tabulates the difference between iron deficiency anemia and an inflammatory or anemia of chronic disease. So anemia in iron deficiency anemia can range from mild to severe. In inflammation, it is usually mild. Individual will have an hemoglobin of somewhere between 6 to 8. So the mean corpuscular volume is somewhere between 60 to 90. It is not much decreased here. Morphology, in iron deficiency anemia, it is usually microcytic hypochromic anemia. In inflammation, majority it is normocytic normochromic anemia. Sometimes there can be microcytic hypochromic anemia. So serum iron is less than 30. It's somewhere between 50, 40. Total iron binding capacity is increased. So here, these last 4 parameters are most important. That is total iron binding capacity, transfer in saturation, serum ferritin, and iron stores. So let's talk about TIBC. TIBC is increased in iron deficiency anemia. It is decreased in anemia of chronic disease. Transfer in saturation is less than 10% in severe anemia, while it is 10 to 20. Serum ferritin is less than 15. And here in anemia of chronic disease, it is elevated. Now, why is this elevated? You have to ask yourself, why is serum ferritin elevated in this kind of anemia? Because one reason is there is a lot of stored iron available. Second reason, I told you ferritin is a marker of acute phase reactant. So it is elevated in the background of anemia because there is already an infection undergoing, or there is already a cancer process that is undergoing, which is causing your increase in serum ferritin. So when you look for iron stores in a bone marrow biopsy, there will be literally no or absent iron in the bone marrow, while it can range to 2 to 4 plus when you take a bone marrow in an individual with anemia of chronic disease. So to summarize, anemia of chronic disease is basically a very close differential diagnosis for a clinician to differentiate from iron deficiency anemia. This is very much important because when you diagnose an individual with iron deficiency anemia, you keep on giving him correction, either by an oral therapy or a parenteral therapy, and you keep him on follow-up, and the individual is not at all recovering. Then you are in a fix. Then you have to find out why is it occurring. Either there is a loss, or either there is no response to treatment, or either your diagnosis is wrong. So in an individual who has anemia of chronic disease, giving him more iron is not going to be beneficial. In those individuals, only one thing that can help is eradicate the cause. And second, you can use supportive measures like you can give erythropoietin or you can give transfusions. So to summarize, both the topics, that is iron deficiency anemia and anemia of chronic disease, most common form of anemia accounting for up to 50% is your iron deficiency anemia. Iron deficiency anemia occurs either as a lack of supply, higher demand, or loss of iron in form of bleeding. As I told you, when someone asks you what are the causes of iron deficiency anemia, categorized into 3. Iron absorption is key and is controlled by various factors, which can upregulate or downregulate accordingly. Hepcidin downregulates ferroportin, which is a gastrointestinal cell iron transporter protein. Microcytic hypochromic anemia is seen on PBF along with pencil cells, cigar cells, target cells, and anisopoikilocytosis. Anisopoikilocytosis forms the basis for red cell distribution width, which is increased in iron deficiency anemia, which is normal in thalassemia. Normal serum iron, normal transfer in saturation with normal Menza index indicates thalassemia. Normal iron stores, normal TIBC, and high ferritin indicates anemia of chronic disease. Normal serum iron and normal stored iron indicates MDS. You would also find a ring sideroblast in an MDS. Management includes treating the cause, packed red cell transfusion, iron therapy, and erythropoietin if you're suspecting an anemia of chronic disease. So that marks the end of discussion for today. That was iron deficiency anemia and anemia of chronic disease. Whenever you get a patient in clinic in whom you are suspecting an anemia, especially an iron deficiency anemia, don't miss the clinical evaluation. You are going to examine his hands, his face, his eyes, look for pallor everywhere that you can see. Look for koilonychia, look for chiliosis, so that you should never miss an iron deficiency anemia. And when you talk about iron deficiency anemia, you should know in detail about where the iron is absorbed, how you get the iron sources, how it is absorbed, how it is transported, where it is stored, what happens to this iron which is not utilized in the heme synthesis, and how it further metabolizes. Where do you get iron apart from the dietary sources? And what clinical features you would find in an individual with iron deficiency anemia, and what is the management strategies, in whom to transfuse, in whom to give iron therapy, oral therapy, in whom to give parenteral therapy, needs to be understood in detail, because this is the most commonest disease. Each and every one of you is going to go ahead and treat all the patients with iron deficiency anemia in your lifetime. So it is very much important to understand iron deficiency anemia. At the same time, it is also important to distinguish it from the three most important differentials, which are close differentials of iron deficiency anemia, that is anemia of chronic disease, myelodysplasia, and thalassemia. So that's all for the discussion of anemia of iron deficiency anemia and anemia of chronic disease.